Okay, good morning. So today we'll talk about syphilis. So regarding syphilis, no, before we talk about syphilis, let's discuss first what is a spirochete. So spirochetes are gram-negative microorganisms. They are microaerophilic and usually they have corkscrew motility. Okay. So regarding the disease associated with spirochetes, first, they can cause localized skin infection. Then after that, it will disseminate to the numerous organ. So first is there is skin infection. Then if left untreated, then it will disseminate to other organs. Then after that, it will develop into latent infection. Then if remain untreated, it can cause cardiac and neurologic involvement. Okay, so examples of spirochete diseases, you have syphilis. Okay, so syphilis is an example of uh, disease associated with spirochete. So the agent of syphilis is Treponema pallidum subspecies pallidum. The next is leptospirosis, okay, caused by Leptospira. Then next is Borrelia, okay, another spirochete. Okay, so same characteristic. First, you have skin infection. Then, if left untreated, it will disseminate to other organs. Then it's capable of latent stage or latent infection. And if remain untreated, it can cause cardiac and neurologic involvement. Next, so let's talk about syphilis. So syphilis is the most commonly acquired spirochete disease in the US. And the main mode of transmission of syphilis is via sexual contact. Okay, so early detection is important because there are antibiotics that are capable of providing cure. Okay, so we have antibiotics that are effective in killing the microorganism and that can give cure to syphilis. The agent is Treponema pallidum, subspecies pallidum, and there's no natural reservoir in the environment. So for syphilis, the transmission is transmitted via direct contact, and there's no reservoir in the environment. So transmission, it's direct contact. Then there are identical subspecies of Treponema pallidum, subspecies pallidum. So first is the pertenu that can cause yaws. So yaws is a chronic um, skin infection characterized by papillomas, okay, or non-cancerous lumps and ulcers. So it's a skin infection. Next is endemicum. It's a non-venereal endemic syphilis. Okay, meaning of venereal is associated with kind of sex or sexual intercourse. So non-venereal endemic syphilis. Next is Treponema caritium, the agent of Pinta. So Pinta is a rare infectious tropical disease affecting the skin, and it is transmitted via direct contact or direct or non-sexual contact. Okay, that's for Treponema caritium. Then next is you have the tromps. Okay, so syphilis contains tromps and the or it has tromps, and the function of tromps is to delay the host immune response against syphilis infection or against syphilis or the spirochete. So meaning of tromps is treponemal rare outer membrane proteins. Okay, treponemal rare outer membrane proteins. And the purpose of treponemal rare outer membrane proteins is to delay the host immune response. So it delays the effect of CTL and also the effect of antibody. Okay, so that's the function of tromps. And syphilis uh, has tromps. Okay, or not syphilis, but Treponema pallidum. Okay, so Treponema pallidum contains tromps. Okay, syphilis is the disease. The agent is Treponema pallidum, subspecies pallidum. Okay. Next is the mode of transmission. So for the mode of transmission, it's rapidly destroyed by heat, cold, and drying. So the means of transmitting syphilis is via direct contact, especially sexual transmission. Okay, so this is the primary. There's also the uh, perinatal transmission. You have the transfer of syphilis from mother to child, and parenteral. But for parental, it's rare. So for example, blood transfusion. No? So during blood transfusion, usually before that blood transfusion, the blood products are stored in the refrigerator. So temp in refrigerator, it's cold. Uh, so the microorganism will be killed because of due to the cold temperature in the refrigerator. So after storage, next is blood transfusion. So during blood transfusion, the organism is already killed. So there's no transmission of uh, syphilis via blood transfusion, unless if you're going to transfuse fresh blood. So after bleeding from a donor, after bleeding of the donor, next is you transfer or transfuse that one to the patient, then there's a high probability of transmitting syphilis. But the usual process of after bleeding next is to store the blood sample in the refrigerator. That can kill the agent of syphilis. So it prevents the transmission of syphilis from the donor to the recipient or patient. Next is you have the four stages of syphilis. So the primary stage is the first stage, and characteristic it's the presence of chancre. Okay, so chancre, it usually develops 10 to 90 days after infection. It is a painless, solitary lesion characterized by raised and well-defined borders. So you have skin lesions. Okay, that's for chancre. And for chancre, in men, it is located outside of the penis, so it is easily detectable. But for women, it's usually present in the vagina or the cervix. That's why it's usually undetected, okay, or undetectable. So it's difficult to diagnose or to detect chancre in women than in men. Okay, so the chancre usually lasts for 1 to 6 weeks, and after that, lesions heal spontaneously. Okay, but it doesn't mean that the syphilis, the agent of syphilis now is absent. It stays in your body for a long period if left untreated. Okay. Next is the secondary stage. So for secondary stage, you have dissemination of the microorganism to the different organs. Okay. So it usually happened 1 to 2 months after the disappearance of the chancre. So symptoms, you have generalized lymphadenopathy, malai, okay, malai or general feeling of discomfort, then fever, pharyngitis, rash on skin and mucous membrane, and there's also CNS involvement. So you have the dissemination of the Treponema pallidum to the CNS. So 40% of patients will show neurologic signs. So for neurologic signs of syphilis, you have you have visual disturbance, hearing loss, and facial weakness. So um, visual disturbance, hearing loss, and facial weakness, some of the neurologic signs of syphilis. So that's for the secondary stage of syphilis. Okay, so next is the latent stage. So you have the disappearance of secondary syphilis, no symptoms. It's non-infectious except in pregnant women. So during latent stage, uh, there is the possibility of perinatal transmission. Okay, so transmission from the mother to the fetus, okay, during the latent stage. Next is tertiary. So it usually develops 10 to 30 years following the secondary stage. And there are three major manifestations of tertiary syphilis. So first is the presence of gommas. So it's a localized areas of granulomatous inflammation that are most often found in bones, skin, and subcutaneous tissue. So the lesions usually contain lymphocyte, epithelioid cells, and fibroblastic cells. And the presence of gommas, it represents the host response to syphilis or host response to infection. So that's why the lesion contains lymphocyte, epithelioid cells, and fibroblastic cells. So it is a host response to the infection. So next manifestation, you have cardiovascular complications. So it involved the ascending aorta. So you have destruction of the elastic tissue in the aortic arc. So this one can cause aortic aneurysm. Okay, aortic aneurysm. The next is neurosyphilis. So complication often associated with tertiary stage, but it actually can occur in any time after the primary stage and can span all stages of the disease. So regarding neurosyphilis, this one may also happen during the secondary stage of syphilis infection, okay, and also the latent infection. So for neurosyphilis, HIV patients are susceptible to early neurosyphilis because HIV individuals are immunocompromised. Then the early manifestation of neurosyphilis is acute meningitis. So if there's meningitis and there's uh, no, the early manifestation of neurosyphilis is acute meningitis, meaning there is inflammation. Meningitis, you have inflammation due to the presence of the microorganism into the brain. Next is latent manifestation. So for late manifestations of neurosyphilis, you have degeneration of the lower spinal cord with partial paralysis and chronic progressive dementia. Okay, and it usually need 10 years to develop neurosyphilis. And the reason why there's neurosyphilis is due to the structural damage of the nerves, okay, due to the presence of the spirochete. Okay, so that's for neurosyphilis. Next is congenital syphilis. So it occurs when a woman has early syphilis or early latent syphilis transmits treponems to the fetus. Okay, so there is perinatal transmission. So fetal or perinatal death occurs approximately 10% of the cases. Okay. Newborn usually asymptomatic during the first week of life, and 60 to 90% of infants develop symptoms if not treated at birth. And the usual symptoms of congenital syphilis, you have clear or hemorrhagic rhinitis and the presence of maculopapular rash that is prominent around the mouth, palm of the hand, sole of the foot, and there's also the appearance of neurosyphilis in congenital syphilis, about 60% of the cases. Okay. Okay, so next is the defense mechanism of the host against syphilis. So for primary defense mechanism, you have intact skin and mucous membrane. So intact skin and mucous membrane prevents the entry of the microorganism. Then next, if in the primary lesion, you have the presence of CD4 cells and cytokines. Okay, presence of CD4 cells. The function of CD4 cells is to um, activate, okay, other cells that can help in the uh, um, can help in fighting the antigen. So CD4 cells will produce cytokine, and the cytokine will give signal to the macrophage or macrophage to eat the antigen present in the lesions. So in this way, the chancre will heal because of the action of the macrophage. Next is antibodies, the formation of antibodies. So coating the treponems does not ultimately bring destruction. So regarding antibodies, it's not that effective in neutralizing the antigen. So the presence of macrophage is more helpful than the production of antibodies. Next is the defense mechanism of the agent. So for the defense mechanism of the agent, it's capable of coating itself with host proteins to delay the recognition of the antigen. Okay, so that's why there is TROMS. Meaning of TROMS is treponemal rare outer membrane proteins. So these are host proteins na coat dito sa body of the spirochete, and it will delay the recognition of the antigen. So if we talk about CTL, the CTL cannot easily recognize the or the macrophage cannot easily recognize the infected cell or the spirochete, the antigen, because the membrane or the body of the spirochete is covered with TROMS. Okay, so dili siya ma-detect sa imong immune cells, or late siya ma-detect because of the TROMS present sa body sa spirochete. Then it's also capable of latency or latent infection. Next is the laboratory diagnosis of Treponema pallidum subspecies pallidum. So first is direct detection. Direct detection of the spirochete in patient specimen. The next is the measurement or detection of non-treponemal serological tests. So for example, the antibody reagene. Okay. The next is the identification or determination of treponemal serological tests or antibodies against treponema. So non-treponemal antibodies and treponemal antibodies. So for the first one, it's direct detection, meaning you are going to detect the antigen or the presence of the spirochete in patient specimen. So for direct detection, you can perform dark field microscopy or fluorescent antibody testing. And note, patients should have active lesion to perform direct detection. Okay, you need active lesion, the presence of chancre, to detect spirochetes or the Treponema pallidum subspecies pallidum. So under direct detection, you have dark field microscopy. So for dark field microscopy, it is useful during the primary and secondary syphilis. You cannot use dark field microscopy during the latent stage of the infection because you cannot isolate or detect, or no, you cannot detect the spirochete during the latent stage of infection. Then you need exudates from skin infection. Okay, so skin lesions. So you need to extract skin, exudate from skin lesions for you to perform dark field microscopy. Next is identified on the basis of corkscrew morphology and flexing motility. So you have your skin lesion, then collect exudate, then you examine the exudate directly, okay, using microscope, okay, dark field microscope. Then uh, observe for the presence of corkscrew morphology and flexing motility. So observation of motility is key in dark field microscopy. So you need to examine the specimen quickly as possible. The purpose of that one is to avoid drying out of specimen because drying can cause uh, false negative result because namatay na ang uh, bacteria. Okay? So to avoid nga makill ang bacteria, you need to process the specimen as soon as possible. Okay? To avoid drying out. Okay? So you have your skin lesions, collect exudate, then directly view or observe for the presence of corkscrew morphology and flexing motility. So cause of false negative result, they have delay in evaluating the slides. So you have drying out of the specimen, insufficient specimen, and pre-treatment with antibiotics because there are antibiotics that are effective in killing the antigen or that can give cure to syphilis. So if there is pre-treatment with antibiotics, expect that you'll have false negative result. You cannot observe for the antigen or the bacteria or the spirochete itself. Okay, it's because of the intake of antibiotics that is effective in killing the antigen or the spirochete. Okay, so next is fluorescent antibody testing. So for fluorescent antibody testing, we're going to use uh, substance with link or bind to no, we're using antibody or AHG that are linked to or with labeled with a label, and that label is uh, capable to fluoresce, okay, or give naimoglow. Okay, so the principle, you have two methods, direct and indirect. So for direct, you have antigen of treponema present in patient serum. Then you add antibody with fluorescence nga label or substance capable of give capable nga to fluoresce or muglow. Okay, so you have antigen plus antibody with label. So if there's a reaction, once you view it in the microscope, you have fluorescence microscope. So there is light or kanabang mo glow. Okay, if there is antigen antibody reaction, no antigen, no glow. Okay, that's for fluorescent labeled fluorescent antibody testing. For indirect, it's antigen present in the patient serum plus antibody, the first reagent, and the second reagent is AHG with label. Okay, so if there's antigen antibody reaction, the AHG will react with antibody. Then after that, you have fluorescence. So there is cannot mo glow, but no antigen, no reaction, no glow nga ma-form or ma-produce. Okay, so that's for indirect. Now, for fluorescent antibody testing, live specimens are not required. For uh, dark field microscopy, you need live specimen. So for this one, no need for skin. No, kaya mga dapat ma-process nimo siya immediately. No, dili na need ana. So, ang specimen, pwede natay delay of processing because ang ato ang important lang is the antigen, not the, what you call this, the bacteria nga ma-observe nato with corkscrew motility. Okay? So, we're detecting for the antigen. And cross-reactivity may happen. That's the negative or disadvantage of fluorescent antibody testing because you're using antibody. And sometimes some antibodies have the ability of reacting with other antigens, and that can give you false positive result. Next is you have serological tests. So for serological tests, these are applicable in patients with no lesions. Okay, so example, secondary and latent infection. Okay, so for serological tests, you have non-treponemal and treponemal tests. So for non-treponemal, these serves as screening test, high sensitivity, easy to perform. False positive may occur due to non-specificity of the antigen. And if there's a positive result, then you need to confirm it using treponemal test. So under serological test, you have treponemal and non-treponemal. For screening, you can use non-treponemal. For confirmatory, use treponemal test. Reason for this one, for treponemal, you can check or you can detect treponemal antibodies during the early and late stage of the disease. But for non-treponemal, it's usually absent during the late stage of the disease. Okay, so next is non-treponemal test. So for non-treponemal test, determine the presence of antibody against cardiolipin. So this is the antigen. Cardiolipin, it's a lipid material released from damaged cells. And the antibody that we're going to detect is the reagine. So reagine is the antibody against cardiolipin. So reagine is a non-treponemal antibody. So it's detectable in patients with syphilis. Okay, so your body will produce reagine once you have syphilis infection. So the purpose of non-treponemal test is to detect reagine, the antibody reagine. It's either IgM or IgG. Next, so to detect reagine, we have two tests. First is VDRL and second is RPR. So VDRL, that's your Venereal Disease Research Laboratory, meaning of VDRL. Then RPR, that's Rapid Plasma Reagine. So the principle is flocculation reaction. So when you say flocculation reaction, that is a specific type of precipitation reaction. And regarding non-treponemal test, it's usually positive within 1 to 4 weeks after the appearance of chancre. Okay? And titers peak during the secondary stage or the latent stage of the infection. So primary, there is 13 to 41% non-reactive results. Secondary stage, diba, you have primary, secondary, latent, and tertiary. So primary stage, there is 13 to 41% non-reactive result. Then for secondary, almost all patients have reactive test result because during the secondary stage have the peak in the production of reagine. Now, if there's a false negative result, probably it's due to prozone or there is antibody excess. Okay. Next, titers tend to decline in the later stages of the disease, even if the patient remains untreated. So usually, reagine is undetectable during the late stage or later stages of the disease. So during latent and secondary, you have peak levels of reagine, but during the tertiary, you have a decline of the production of non-treponemal antibodies like the reagine. Next, the decline occurs more rapidly in individuals who have received treatment. So the decline in reagin is fast in individuals who receive treatment against syphilis. Next is following successful treatment, tests typically become completely non-reactive within 1 to 2 years. Okay, so that's for non-treponemal antibody test. So for non-treponemal antibody, you have your reagin. So both VDRL and RPR, we're going to detect the presence of reagin. And remember, during the primary stage, it's usually non-reactive, but during secondary and latent, that's the time you have peak levels of reagin. But during the tertiary stage, you have start in the decline of reagin concentration. Next is for your VDRL test, you can use serum or CSF specimen. So the antigen that you're using is a combination of cardiolipin, cholesterol, and lecithin. So this is your VDRL antigen plus saline solution. That's for the preparation of your VDRL antigen. Okay, that's the composition of your reagent. Then you need to heat inactivate the serum specimen at 56 degrees Celsius for 30 minutes. Then for the control, you have non-reactive, minimally reactive, and reactive control. Then serum plus VDRL and antigen rotated for 4 minutes at 180 RPM. Then you need to read the result microscopically. Okay, so have your slide, then your slide plus serum, then the VDRL reagent, then you rotate the slide for about 4 minutes at 180 rotations per minute. And then after that, read the flocculation reaction or precipitation reaction uh, microscopically. Next is the RPR test. So it's a modified VDRL test, and it's more of macroscopic agglutination rather than microscopic reaction. So for this one, you're using charcoal as the carrier of the antigen. So you have black precipitate or black agglutination due to the use of charcoal. Okay, and it's more sensitive than VDRL in the detection of primary syphilis. Okay, so these are the two non-treponemal tests. Purpose is to detect reagin, the antibody against cardiolipin. Next is treponemal test. So it detects antibody directed against treponemal pallidum organism or against specific treponemal antigens. It becomes positive before non-treponemal test. So during the primary stage, it's usually non-reactive, but during secondary and latent stage, it is usually 100% reactive ang result. So once a patient is reactive, that individual remains so for life. So the antibodies against treponemal pallidum will remain in your system. For reagin, during the tertiary stage, bumaba na to siya. But for treponemal antibodies, it will remain detectable. Okay. Disadvantage, it's the reactivity with other treponemal diseases like Yos and uh, Pinta. Okay. So that's for treponemal test. You're detecting antibody against treponemal pallidum. First, you have the treponemal antibody testing. So for treponemal antibody testing, first you have fluorescent treponemal antibody absorption test or FTA-ABS test. So the purpose of this one is to confirm the positive non-treponemal test result. Okay, so we have screening the non-treponemal, and for confirmation, you have the treponemal antibodies. So that's the traditional testing algorithm. So you'll use non-treponemal for screening, and for confirmation, you have treponemal testing. So the step for FTA-ABS, first is you incubate the specimen with the antigen that you're using. Antigen is the part of the reagent. So you incubate the serum and the reagent for about 30 minutes. So the purpose of that incubation or rationale is for the antigen to react with the antibody present in patient serum. So you have antibody patient in patient serum, then you have the antigen present in the reagent. So reagent, serum. Okay. Next is you'll add labeled AHG with fluorescein. Okay. So plus AHG with fluorescein. So the label is a fluorescein. So it gives color. It will glow. Okay. Muna siya color. So the intensity of the green color is reported on a scale of 0 to 4 positive. No fluorescence, meaning it's a negative test. 2 plus or above, that's reactive. And 1 plus, repeated with a second specimen drawn 1 to 2 weeks. So the reason why you need to uh, repeat testing if the result is 1 plus, because there's a possibility. Uh, what if the amount of antibody produced during the time of collection is not the peak of the antibody production? So you let the antibody production reach its peak, so that after 2 weeks you'll get a positive result. Okay, a clear positive result. So for this reaction, our unknown is antibody. Now, for example, if the antibody is not present in patient serum, there's no fluorescence or negative for fluorescence, because this one will only react to the antibody. Okay, so or antigen antibody complex. So no reaction, no fluorescence. But if the antibody is present, so the antibody will react with the antigen. The next is the AHG will react with the antibody, and it will give fluorescence. Okay. So regarding this test, it is specific and sensitive, but the problem is time consuming, and it is replaced with particle agglutination method. Okay. So I'll repeat. If the result is 1 plus, then you need to repeat the testing and draw or collect another specimen or a new specimen 1 to 2 weeks after. Okay, so reason, let the body produce more antibody so that it will give you a clear positive result the next testing. Okay, So if the result is 2 plus or above, that is reactive. No fluorescence, that is negative. Okay, the purpose of this test is to detect the antibody against treponema in patient serum. Next is you have particle agglutination method. So for particle agglutination method, first, uh, you can use SHIP RBC as indicator or carrier of the treponemal antigen. So same with FTA-AEBS, this method is to determine antibody present in patient serum. Okay, then you add the reagent. The reagent is SHIP RBC coated with treponemal antigen. So if antibody is present in patient serum, it will react with the antigen, producing agglutination. Okay, so no antibody, no reaction, no agglutination. That's for particle agglutination method. Now, modification of particle agglutination method, you have your Serodia T pallidum particle agglutination method, your TPPA test. So it used colored gelatin as the carrier instead of SHIP RBC. So the gelatin is coated with treponemal antigen, then it will react with the antibody present in patient serum, then you'll have agglutination. Okay. Now, regarding this antigen coated sa gelatin particles, it is placed in a microtiter plate. So, ginambutang siya sa microtiter plate. And after that, next is you add the serum specimen sa microtiter plate that contains T pallidum sensitized gel particles. Then after a few minutes, you have agglutination reaction. So if there's agglutination, that is reactive. Negative if the gel particles settle to the bottom. Okay, so that's for T pallidum particle agglutination method. So for agglutination, mo-float siya. You have uh, kato siya mga floccules or granules nga ma-form. Dili siya mo settle sa bottom. Okay, but for negative, mo settle sa bottom ang gel. Okay, because of no agglutination reaction. Okay, so this is more sensitive in detecting primary syphilis. Next is automated assay. So for automated assay, you have your enzyme immunoassay, and there are two ways. You have sandwich assay and immune capture format. So for sandwich assay, you're going to measure or detect antibodies in patient serum. Then you place the serum in microtiter plate. Then the microtiter plate is coated with T pallidum antigen. Okay. Then next is you add enzyme labeled antibody. Then you have the reaction between you have antibody from patient serum, then the antigen present on the microtiter plate. Then you add another antibody with label, which is the enzyme. Then uh, this is sandwich immunoassay. So ang purpose is to detect the antibody, but it competes with no. Dili siya marabag you have two antibodies, one from the reagent and the other is from the patient specimen. Okay. Now, to determine the concentration, since you're using enzyme as label, so determine the concentration, you need to add the substrate. Okay. Next is immune capture format. So for immune capture format, microtiter coated with antibody against IgM plus serum. So serum contains the antibody, okay, which is it's either IgM or IgG, okay, plus enzyme labeled antigen, okay. So this one is against IgM, that is AHG, okay. So this one will react with the antibody, and this one will react with the antigen labeled with enzyme. Okay, so same thing with sandwich assay, you need to add substrate as indicator or to determine the concentration of the antibody. Next, it is useful in diagnosing congenital syphilis because they look for the presence of IgM. Now, regarding IgM, the presence of IgM means the baby has syphilis. Okay. Now, if the serum of the baby contains IgG, then no IgM, then it indicates that there's um, transfer of antibodies from mother to child. So the significant one, the significant antibody, it's IgM because this one indicates uh, current infection. Okay, uh, the baby has congenital syphilis. Okay, if IgG lang after birth na siya IgG, then it indicates transfer of antibodies from mother to child. Okay, next you have the clinical applications of non-treponemal test. So it's sensitive, inexpensive, simple to perform, useful as screening tool. Disadvantage of a lot of false positive result. So cause of false positive result in non-treponemal test, you have hepatitis, infectious mononucleosis, varicella, herpes, measles, malaria, tuberculosis, pregnancy, SLE, leprosy, autoimmune arthritis or your rheumatoid arthritis, and advanced age and malignancy. So for non-treponemal, it's confirmed by a more specific treponemal test. And for treponemal test, it distinguishes false positive from true positive non-treponemal results. So it's more sensitive, specific than non-treponemal. So it helped establish a diagnosis in latent syphilis or late syphilis because uh, treponemal antibodies is always present, okay, in latent and late syphilis. During late syphilis, there is a possibility that non-treponemal antibodies are absent, okay, or it will disappear during the late syphilis. Disadvantage, difficult to perform. So for testing algorithm, right now we're following the reverse sequence algorithm, okay? Reverse sequence algorithm, okay? So before we followed the traditional algorithm. So for traditional algorithm, first is you need to perform RPR or VDRL. So RPR or VDRL is non-treponemal test, okay? So for non-treponemal test, if the result is non-reactive, then automatic, there is no further testing, the result is negative for syphilis, or the patient is negative for syphilis. If the result is reactive, then you need to perform treponemal test. Okay? So for treponemal test, if the result is reactive, then it is positive, the patient is positive for syphilis. So treponemal test, example you have your agglutination method, your TPPA, and your FTA-ABS. Okay, so those are the examples of treponemal test. Next is non-reactive, then meaning you have false positive result in your non-treponemal test. Okay, so this is the flow for the traditional algorithm. Next is reverse sequence algorithm. So this is the algorithm that we are following right now. So reason, it is cost effective, less error because it's usually automated, performed using uh, what do you call this? Um, perform using machines. So example, you have your enzyme immunoassay. So instead of performing non-treponemal, you're using treponemal test for this as the first test. Okay, so you have EIA as the first test instead of non-treponemal test. Then if the result is negative, then the patient is negative for syphilis. If it is positive, then you'll perform non-treponemal test. So in non-treponemal test, if the result is positive, then the patient has positive the patient is positive for syphilis. If negative, then you need to confirm it. Okay, so so the confirmatory is TPPA test. Okay, so if the TPPA test is negative, then meaning you have uh, negative, the patient is negative for syphilis, uh, meaning what do you call this? Uh, the patient yun kay negative siya for syphilis, but if positive siya under TPPA, so positive for syphilis, so the patient is positive, and the reason why the result is negative right here, and yeah, positive in this area, or positive in TPPA, negative in RPR VDRL, maybe the patient is or has early syphilis or past syphilis or late syphilis, because in late syphilis and early syphilis, the RPR or VDRL will have a negative result. Okay, kaya diba non-treponemal test man sila. So for late syphilis and early syphilis, it's better to use TPPA. Okay, so if negative, then positive, then that's an indication of late or early syphilis. Okay, so that's why we're using this one to detect early and late and also treated syphilis, the reverse sequence algorithm. So it is cost effective because once the result is negative in EIA, then no further testing. Okay? Unlike sa imuhang the traditional kay murabag if positive siya sa non-treponemal, then you need to check pa or siya double na, and mas cost effective ni siya kumpara sa imuhang uh, traditional algorithm. Okay, so if the result is positive in EIA, then you'll have RPR. And if positive in RPR, then you'll have positive for syphilis. Okay, so if this is negative, positive, that's an indication of early or late or treated syphilis. If the result is negative, then that's true negative. Okay, negative for syphilis. Okay, so that is the reverse sequence algorithm. This is what we are following right now. Next is molecular testing. So for molecular testing, extremely sensitive technique capable of detecting as little as one treponym in some clinical samples. Sensitivity is highest in patients with primary syphilis, but is greatly reduced in detecting disease in secondary syphilis. Okay, so regarding molecular testing, um, its application is more of the early syphilis, okay, the primary syphilis. During latent stage, you cannot use primary molecular testing. It's difficult to isolate um, treponema in late stage of the disease. May provide a viable alternative to dark field microscopy, and it's helpful in detecting treponems in the blood of neonates with symptoms of congenital syphilis and in CSF of patients suspected of having neurosyphilis. Then next, regarding congenital syphilis, we are more concerned of IgM. So that's why um, the test is EIA capture, okay? Enzyme immunoassay IgM capture, because we want to detect the presence of IgM antibody, because this is an indicator of current syphilis, current infection. Next is confirmation. If the first test, the IgM capture assay is positive, then you need to confirm it using Western blot. Okay. Next is CSF. So for CSF, it is used. This specimen is used to diagnose neurosyphilis, and uh, we can perform VDRL in CSF. It's diagnostic because false positive in VDRL using CSF specimen is extremely rare. You can also perform ELISA and PCR using CSF specimen. Okay, purpose to detect neuro or to diagnose neurosyphilis. Okay, so the next topic, you have Salmonella typhi. So for Salmonella typhi, um, it is the agent of typhoid fever. Okay, so it is endemic here in the Philippines. So most of us are exposed now, already exposed to Salmonella typhi. Next is you have febrile agglutination test. So example of febrile agglutination test, you have the Widal test. So um, it is a bacterial agglutination test classified as a febrile agglutination test. So febrile agglutination is caused by bacteria and all diseases characterized by fever. Then next is you have whale Felix test. So for whale Felix test, it is uh, used to test for rickettsia and proteus. And that's for whale Felix test. You're using proteus antigen to detect presence of proteus antibodies against proteus antigen. Same with rickettsia. So you're using rickettsial antigen to detect antibodies against rickettsia. Okay, that's for whale Felix test. So in the detection of salmonella antigens, we're using um, three antigens. They have H, O, and K antigen. Okay, so H, thermolabile antigen specific for a given species and found in the flagella. So this is the flagellar antigen. Okay, flagella. So if this is the body of a microorganism or bacteria, the flagella, okay, di ba kana? Flagella. Okay, responsible for the movement or motility of the microorganism. The next is O antigen, so thermolabile somatic antigens, somatic O, which are not species specific and directly associated with bacterial body. So it's located right here. Then K antigen, thermolabile antigen, which occurs in capsules or envelopes of the bacteria. So uh, this is present in the capsule. Okay, so these are your VI antigens in Widal test. Okay, so you have O and H, and for K it's VI. Okay, so H, O antigen, then for K it's VI antigens using Widal test. So Widal test, it is an agglutination test that requires no serum activation. And it's based on agglutination reaction. Agglutination occurs when specific antibody is found in the patient's serum. So the purpose of Widal test is to detect antibodies against Salmonella typhi in patient's serum. So titer is the highest serum dilution with 2 plus agglutination. For 2 plus agglutination, if you're using tube method, okay. But for slide method, you cannot classify 2 plus agglutination using slide. You can only classify 2 plus agglutination using test tube or tube method. It's a diagnostic test for Salmonella typhi and Salmonella paratyphi A and B infection. No reason to perform in areas with low incidence of typhoid fever, and capability of the microbiology laboratories to recover the organism in culture is up to date. So for example, America, they don't need to perform without test because they have low incidence of typhoid fever. Same with Japan. Okay, their chickens are usually negative for salmonella, and they have up-to-date laboratory methods of isolating the microorganism. Alternative to without test is the typhi-DAT. So for typhi-DAT, you're detecting IgM or IgG antibodies against Salmonella typhi. So it's more specific and reliable. But in endemic areas with no typhi-DAT and no culture facilities, you can still use without test. Okay, so you're going to use without test if your area has no typhi-DAT available and no culture facilities to isolate Salmonella typhi. Okay. Patients who have experienced bouts of S. typhi infection are immunologically primed to generate a brisk antibody response to S. typhi antigens O and H. So regarding here, no, regarding Philippines, Philippines, Salmonella typhi is endemic in the Philippines. So we'll expect na if we're going to use without test, most of us will have a positive result because I'm sure most of us can expose na sa past sa Salmonella typhi. Dili lang severe ang fever, na may mga moderate or low grade lang typhoid fever. Okay? So, that's why without test is not reliable. Okay? Samot na diri sa Philippines nga endemic ang 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 Salmonella typhi. Next, you have typhoid fever. So typhoid fever is only seen in man. An organism is ingested by eating contaminated food or drinking contaminated water with feces of infected person. So the transmission of typhoid fever or salmonella typhi is more of fecal-oral or fecal-oral route. The incubation period, it's 8 to 14 days. Symptoms of typhoid fever, you have fever, headache, myalgia. So myalgia is muscle pain, GIT problems, splenomegaly, and rose spots on the abdomen. And regarding the microorganism, the Salmonella typhi, it is present or seen in stool for the first week of infection and for urine until the second week of infection. Then for the first 2 weeks, positive stool, urine, and blood culture. But after that one, it's usually negative na. So that's why you have your Widal test to check for antibodies because it's difficult to isolate na the microorganism after 2 weeks. So it's recommended during the third and fourth week of infection, but if you have typhidat, then perform typhidat instead of Widal test. Okay, so it's more sensitive and specific compared to Widal test. Then next is you have your Salmonella paratyphi A and B, your Salmonella choleraceus. So it's a non-typhoidal salmonella. It's not the causative agent of typhoid fever. Primary pathogen of animals, humans, as well as in poultry, pets, cows, and pigs. It results to bacteremia and enteric fever. So usually the disease associated with paratyphi is enteritis. Okay, so enteric fever, body responds to this antigenic stimulation by producing antibodies whose titer rises slowly in the early stage, increases then falls till it is undetectable. However, in endemic areas, antibody titers up to 160 may be detectable in normal population. So regarding paratyphi, it's associated with enteritis. It's not associated with typhoid fever. Okay. Okay, so for the test principle of Widal test, when the colored, smooth, attenuated Widal antigen suspensions are mixed, incubated with patient serum, anti-salmonella antibodies present in the serum react with the antigen suspension to give an agglutination. Agglutination is a positive test result indicating the presence of anti-salmonella antibodies, and no agglutination is a negative test result indicating the absence of anti-salmonella antibodies. And this one is for qualitative, but if you are going to perform semi-quantitative, you need serial dilution. And a 1 is to 80 or a titer of 80 is it's suggestive of infection. Okay, so for the testing, diba, you have your um, colorless or transparent slides. Then after testing the positive and negative control, you can proceed with the testing of patient specimen. So for the testing of patient specimen, you need 50 UL of patient serum. Then you need 2 circles. This is for O and H. Okay, so the reagent contains O antigen and H antigen. One bottle for O, one bottle for H. Then 50 UL of patient serum, 50 UL of patient serum. So if the patient serum contains anti-O, okay, anti-O antibody, so if you add the reagent, then there will be agglutination. So for example, if patient serum does not contain H antigen, no antibody, so no H antibody, then you add H antigen, the result is no agglutination. Okay, so for example, if the pattern or the result is positive for O antibody and negative for H, then this one indicates current infection. Okay, if the result is negative for O, positive for H, it is indicative of past infection. But if the result is positive and positive, then it indicates current infection. But if you have a positive result, you need to proceed to uh, uh, semi-quantitative. And in semi-quantitative, you need a titer of 1 is to 80. So uh, perform serial dilution, and if the test or the test tube with 1 is to 80 dilution will have a positive or will have agglutination, then that's indicative of a positive result. Okay, so if you want to confirm whether there is disease or infection, then you need to perform semi-quantitative, and the titer should at least 1 is to 80 or 80. The titer that indicates positive infection, positive for infection, it's 80. Okay. Now, same principle applies to uh, paratyphy. So in paratyphy, you have your slide. Okay, so you have AO, BO, then no, AO, BO, then CO. So you have three strains of paratyphy. Then you have your uh, AH, BH, and CH. Okay, so same principle. If the result is positive for O, that's current infection. If the result is positive for H, that is past infection. But if both positive, then that is current infection. Okay, so same, we're detecting for the antibodies. So for AO, BO, CO, AH, BH, and CH, we're detecting for the antibodies against paratyphy. Okay, so for O and H, this is for Salmonella typhi and the antibodies against O and H antigen of Salmonella typhi. Okay, so that's all for Widal test.